Okay, great. Thank you. So good evening, everyone. My name is Arian Hudnall. I'm one of the co-chairs for the Health Committee of the National Coalition of 100 Black Women Incorporated, the Pennsylvania chapter. And tonight we have the honor of hosting Dr. John Marks, who is the Chief of Colorectal Surgery at Main Life Health, to give us a candid conversation about colorectal cancer. So first I will start with a brief bio of Dr. Marks, and then we'll get right into the conversation. John H. Marks, MD, is an internationally renowned colorectal surgeon with recognized areas of expertise in rectal cancer management and laparoscopic and robotic surgery. He is currently the director of colorectal surgery and the chief of the section of colorectal surgery for Mainline Health System at Lincoln Medical Center. Dr. Marks is the director of the fellowship in minimally invasive colorectal surgery and advanced rectal cancer management, as well as a colorectal surgical research team. As one of the world's most experienced colorectal surgeons, he has performed nearly 3,000 minimally invasive colorectal cancer surgeries, including more than 1,400 rectal cancer procedures. His research and educational programs focus largely on minimally invasive laparoscopic and robotic colorectal surgery, featuring radical sphincter preservation resection for rectal cancer after neoadjuvant therapy, one of the largest series of its kind in the world. And with that, Dr. Marks, I will turn it over to you for your talk and let you go ahead and share your screen.
Okay, well, thank you for that wonderful introduction. I have to give me a second to get set up here. I have to congratulate Terrence and Arian for the wonderful introduction, as well as handling all those terms and topics you probably aren't that familiar with. It's really my pleasure to be speaking with you. I'm sorry, as has happened to all of us during this COVID crisis, that we're not able to do this in person. We've been talking about doing this for some time, and I'm happy to do this now, but I look forward to having the opportunity to meet with all of you sometime in the future and take this conversation further. So, you know, all of us have heard of the word colon. It really is a punctuation. It is something we learned about in primary school. And I'm here to tell you that the colon, it's more than just punctuation. You know, I always put this slide up. These are my disclosures, my commercial interests. I have none that should interfere with this talk. And, you know, most of the time people are pretty friendly to me. Sometimes not so much. I hope you guys will be a little bit of a nicer audience than some. So the colon is the formal name for the large intestine. And what I like to tell everyone in explaining this is that the intestinal tract is kind of like a hose. It starts in your mouth and ends down in the anus. And in between is the esophagus and then the stomach. And from the stomach, it goes to the small intestine. And the small intestine empties into the large intestine, which is also called the colon. The colon ends, the sigmoid colon empties into the rectum. And this is what comes through the sphincter muscle and is what gives you bowel control. So the reason we talk about this is that colon cancer is a very prevalent cancer in America. In fact, it's the #1 cancer of the abdomen that affects both men and women. And there are roughly 150,000 new colorectal cancers each year. About 100,000 are in the colon, and the 50,000 of them are just in the very bottom part, which is the rectum, which gets everyone scared because they don't want to have a bag when they're operated on. There are generally about 250,000 colon operations done each year. And so you can see with your focus on cancer and how it affects the African American community, this is something that impacts our community and our country greatly. The lifetime risk is roughly 1 in 20. So if you look to your right, you look to your left in a room, in a classroom, one of those people at least will have colon cancer. And the thing is with colon cancer is that it's completely avoidable. And what do I mean by that? Colon cancer is avoidable because unlike other cancers, it has a pre-malignant condition called a polyp. And so if everyone did colonoscopies, you would find this pre-malignant condition and be able to remove it, and it would pretty much eradicate colon cancer in America. So who knows what this says? Okay, most of you probably got it, but for those of you who didn't, it's check your colon. And, we use the old Nike swoosh and say, just do it. And by that, we mean just go and get your colonoscopy. So I come to you today. This is part of our team. And I'm sure all of you know Michelle. Michelle Parker is so fortunate to have her as part of our staff at the Lankenau Colorectal Center. She's simultaneously my boss, my mentor, my admin and friend, and it's really what she is at her urging that I'm speaking with you, and I'm honored to be able to do so. And just as I know you enjoy and treasure the work she does with you and her friendship, so do we at Lankenau. So this is where I come from, the Lankenau Medical Center. Those of you in Philadelphia, which I think is everyone here, are familiar with it, is the old Overbrook Golf Course. And this is where we're located. And what we're striking, what our goal is to make anyone who has a colorectal condition and call have a 5-star experience from the moment they call to the moment they walk out of the hospital, hopefully cured their disease. What we're looking for is to develop and provide best-in-class medical care as well as patient experience. So we are a destination service for colorectal disease. People come from around the area, nationally and internationally, and what we strive to do is not only live up to people's expectations, but exceed them in terms of the care they receive at Lankenau. And for those of you interested in what are higher risk groups for colorectal cancer, pretty much the 3 biggest groups are those who are obese, the African American community, as well as the Ashkenazi Jewish community, all have higher incidences of colorectal cancer than the rest of the population. So the general rule, and if you're only going to listen to one thing, and kind of the one thing to take home is this, everything else is kind of entertaining, but this is the thing to take home, is everyone should obtain a screening colonoscopy between the ages of 45 and 50. In these groups, that might be 40 to 45 in the African American community. And this is for the asymptomatic patient, the normal risk patient without any family history. In addition, people at any age who have symptoms, and by that I mean bleeding, unexplained change in your bowel habit, unexplained weight loss, abdominal pain, diarrhea or constipation, all of these things in addition should lead you to be evaluated because a cancer can cause these symptoms. So Theodore Roosevelt said, if you believe you can, you're halfway there. So what we're focused on delivering is really what I like to refer to as the tripod of excellence. Excellence in patient care, first and foremost, but also in research and in education. So not only can we give excellent care, but we can develop things and improve things going forward and teach it to others so they can deliver it to other communities around the country. I'm sure you're familiar with the phrase, give a man a fish and you fed him for today. Teach a man or teach a woman to fish. I'm going to change that. Give a woman a fish and you've fed her today. Teach a woman to fish and you've fed her for a lifetime. And that's really what we're all about. So what is colorectal disease and surgery? You know, it's all sorts of things. We do screening colonoscopy. We're involved in proctology, you know, simple things like hemorrhoids and fissures and fistulas and abscesses. Diverticulitis, an inflammation of the colon, is very common in America. Inflammatory bowel disease, which is Crohn's disease and ulcerative colitis. All sorts of pelvic floor disorders, the inability to pass the stool, as well as incontinence we deal with. And then, of course, one of our major focuses, which is cancer and cancer prevention with polyps and cancer of the colon and the rectum. So for me personally, while I really love just about everything about colorectal surgery, except for having to explain to people what I do at a cocktail party. Then you have to listen to the wisecracks. But in terms of what we do, we get to do little things and big things and help people. And my passions, intellectually and professionally, have centered mostly around rectal cancer, specifically how to cure people's rectal cancers with the very highest quality of life. And so for rectal cancer, what does that mean? It normally means being able to cure them without the need for a colostomy bag, but returning normal bowel function. And then to do things in a minimally invasive fashion. And by that, I mean making incisions maybe a half an inch or an inch in size, as opposed to from top to bottom. And now what we've been pioneering is doing the operation entirely without any abdominal wall incisions. So Sir Isaac Newton said we can see further because we stand on the shoulders of giants. And I've had the distinct privilege of working with some of the best and brightest around the world. Central to that is my father, Dr. Gerald Marks, who's really my primary mentor. Some of you may have known him in Philadelphia. He was the only professor of surgery at a medical university in Philadelphia for many decades. He'd been at Jefferson, and we've been out at Lankenau now for over 20 years. So what am I talking about in terms of education, research, and patient care? I'm going to tell you. You know, our focus on education has led us to host, to be involved in lectures around the country and world. And last year, we actually hosted a major international rectal cancer forum, which Michelle was central to helping to organize. This is just showing you some of the doctors from 5 continents around the world and 24 countries. And they all are coming to Lankenau because of the pioneering work we've done in how to treat cancer, use radiation and chemotherapy to minimize the type of surgery we need to do. We run a fellowship so that we're training specialty doctors to go out into the world and bring things elsewhere. We're now actually in our 20th year, and these are some of the universities our trainees have been hired to go to. They're very sought after. We have faculty that we've trained at the Cleveland Clinic, Cornell, University of St. Louis, the National Cancer Institute in Mexico, Columbia University, University of Iceland, down in the Minimally Invasive Center in Havana. So really pretty much all around the world. And there's actually a map that we have in the office which shows where the patients and doctors come from to learn at Lankenau. And this is just highlighting that a year and a half ago, 12 Lankenau grads served as major faculty for the largest minimally invasive society in the world. We're busy academically publishing on many things. This is, some of the book chapters and surgical journals we've published on how to take care of cancer, how to use robots, and how to do it so the patient gets back on their feet quicker with the best possible outcomes. And actually, a year and a half ago, we published this book on rectal cancer and how to take care of it surgically. It's really the first major publication on the topic in over a decade. This is kind of a fun thing. I've had the distinct pleasure and honor of being hosted in different parts of the world to train. This is actually a crazy picture. Outside of Venice, Italy, I was invited to spend a day teaching, and I asked the doctor what it was going to be called. He said it was a day with John Marks. I thought he was kidding until I got there and saw this huge poster on the wall. And this was the auditorium, and I was able to do some live surgery. So we did surgery that was televised to the audience and talked about things so we could discuss it, and kind of a neat thing. In a lot of places, patient care is what I would call a little bit of a Hollywood set. You have people saying, oh, I'm at MD Anderson in New Jersey, or I'm at Penn in Chester, or whatever the cancer center, quote unquote, is. And really, it's kind of like a movie set where they have the fancy names and it looks good from the front, but when you dig down deep, there's not a lot there. And Lankenau, on the other hand, what I would say to you is we really have a mountain of expertise in radiation oncology, medical oncology. We have specialty units in terms of preoperative care. We have a special colorectal intraoperative team. We have a special colorectal unit that the patients go to afterwards so they have the optimal care to get back on their feet as quickly as possible. This is, as of a couple years ago, these were the numbers of cases I've done. And just to put this a little bit into perspective, according to the American College of Surgeons, the average general surgeon in 1 year does between 5 and 7 colon operations. And here you see, I've done close to 3,000 of these minimally invasively, and along with our team, it's well into the range of 4,000 to 5,000. As I said, these pins, which you see in our office, are where the patients have come from. I think it's 38 of the 50 states, and from a multitude of countries from around the world. So what we're trying to do is spread things and teach the doctors so they can bring it to those patients in other parts. They don't have to travel so far, but also offering things when patients have unique problems. So what am I talking about? This is a patient who, believe it or not, I took out his colon a year and a half before this. He came to see me 2 years later, and he'd had this fresh appendectomy site. I said, I don't get it, because this is where I'd done his left colectomy, and what they took out was about 4 centimeters in length, and what I took out was about 1.5 feet in length. And so what we're focused on is doing operations so the patient has so very little trauma, as you can see here with this incision the size of a quarter. We've also worked on, one of the things we're most excited about is this new robot that I've been central in helping to develop. And what this is a robot that goes into the body through a 1-inch incision. And these are the eyes and the hands that you can use. I'd worked on this robot for 4 years, and I was so excited when they finally delivered it to us. We're the first center in the country to have it. And I went down to the loading dock to greet my new machine. And this is what it looks like, just kind of, so you can see that there's wristed instrumentation. There's both an elbow and a wrist. And then the device in the middle are the two eyes. It's a binocular lens. So you have three-dimensional imaging. And this is just showing how you can move your arms to the right and the left. If you take things out of the way, you'll hit the camera. And there's actually a fourth arm that can go in there as well. And so this has allowed us the opportunity to do things through incisions really as tiny as an inch that before this were just impossible to do. And this is what the robot looks like. That was the instruments. This is how it's housed. It's there are four arms that are attached like this. These are the nurses getting things set up with the sterile drapes. And you can see the robot's checking itself with that circular light, and then this is how they move back and forth. And then this is where I sit this is called the surgeon's console, and my eyes are in this center area here, and then I can use and move things with my hands and feet. And this is what it looks like. To the left is the instruments in the body, and to the right are my hands manipulating those instruments and using things while I'm looking through the optical scope at the side of the instrument. So you can see here, it's a one-to-one movement between the instruments. And then my feet allow me to move the camera. This is a picture of the very first single port robot done in America. The blood loss was less than an ounce, and the patient was operated on a Monday, went home 2 days later on a Wednesday, and you can see this is a tiny incision. And this was from a big colon polyp. This is what the device looks like. I apologize, there's a little PR piece they did for me. But this is the more important thing. This is the amount of people who are all working together as a team for the one patient in the operating room that day. And on the one hand, it's pretty amazing what we're able to do. On the other hand, it's understandable when you look at the number of people, the focus, the interest, and the expertise that is deployed for the care of the patient. This is Lauren. She's our head nurse in the operating room in charge of the colorectal team. And here we are with the robot. And this is some of the other team as we're doing the first case. Everyone's pretty excited. And, you know, so kind of as we move forward, I wanted to tell you a little bit about colon and rectal cancer itself, and then give you a little peek behind the screen at some of the cool technology. And this over here is a device that's on my hand that allows me to teach. So as I raise my right hand to the races, and with my left hand, I can just draw. In the operating room, that allows me to do things for residents to say, hey, take this out or take that out. And so, and over here on the opposite side is the ability to have artificial intelligence implanting the image. And so what you see is on this side, this is where the surgeon thought the tumor was, but when we laid over the imaging, we could see that had he not had this intelligence, he would have been taking out the wrong area of the liver. The fourth leg that I haven't spoken about today, which takes us from a tripod to a full chair, is really philanthropy. And we've been very fortunate through grateful patients and the Rainier Foundation to raise another $1.5 million to help us support the research and work that we're doing at Lankenau. And with that, we're in the process of looking to hire a PhD, a data manager, and to fund further growth. So in summary, you know, we've all had days like this at work, when you're trying to do the right thing and it just doesn't go as you thought it would. And, you know, what we're looking to create is really the next step. And this is, again, what you're able to accomplish with a team both in the office and doing research, as well as in the operating room, because no one can do this alone. It's too complex, it's too much. And here we are with the colon. And this is what we're looking to become, which is a single group of people, all dedicated to the same end, working seamlessly in the care of accomplishing one thing, which is the optimal care of our patients so they can get in and out of the hospital like this. Now, when I figure out how to do that exactly, I'll get back to you, but that's what we're striving for. So, thank you for your attention. I think to be successful in this field, in the field of cancer and colorectal cancer, and do these things, what I like to say is you can swim with the sharks, but you better have a plan. It takes courage and support and a lot of dedication and commitment. And I'm happy to be part of a team that is committed like that. Because everyone recognizes this Philly play. And when everyone works together, you can accomplish great things. So thank you very much. And at this point, I'd be happy to discuss whatever you'd like and take any questions.
Okay, this is Arian again. So I do have a few questions in the chat box from the Facebook Live. So one of the questions is, are polyps the beginning phase to colorectal cancer? And I think you did go over that a little bit briefly in the beginning.
That's a great question. And the answer is yes. The short answer is yes. Not 100% of cancers come from polyps, but probably 95+% do. So this is why colonoscopy is so important, because if you find a polyp and you remove it, you've effectively cured the patient of developing a cancer. So the best way to be cured of a cancer is never to get it in the first place. So that's the whole rationale behind colonoscopy at an early age.
Okay, thank you. And so kind of piggybacking on that about screening with colonoscopy, so this might be a little bit of a two-part question. The first part is, what should the age of screening be for those with a family history of colorectal cancer?
So it depends on the age of the index cancer. So you should be screened at least 10 years before the diagnosed cancer. So if you had a loved one, if you had a brother, God forbid, who had cancer at 48, recommendation would be that you be screened at 38,
Okay.
et cetera. And again, this is all for the asymptomatic patient. If you have symptoms at 25, if you're having bleeding or unexplained change in weight loss, you should talk to your doctor about the notion that you might need a colonoscopy.
Okay. And so another question that kind of went a little bit with that was, should women with other cancer history, either themselves or families, consider screening earlier than what's suggested? So I think you did kind of answer part of that, but are there syndromes of cancers that we should be concerned about?
Absolutely. 70% of cancers are just spontaneous mutations, but about 15% have some kind of familial grouping. About 5 to 8% are in what's called non-hereditary polyposis cancer syndromes. And so the things that are grouped together are ovarian cancer, uterine cancer, gastric cancer, breast cancer, pancreatic cancer. So if you or a family member have those things, then you should be looked at with a higher intensity of scrutiny than if you didn't have that. That would put you not in a low risk group, but in a moderate to high risk group.
Okay. Okay, and then can you speak to what are the beginning signs of colon cancer?
Well, you know, early stage cancer generally is asymptomatic. And again, it gets back to why you want to be screened even if you feel fine. That being said, the most common signs are bleeding, a change in bowel habits, either loosening of your bowels, going more frequently or going less frequently. And that can happen because the cancer can secrete something to give you diarrhea, or the cancer can grow and block off the pipe, so to speak, and constipate you. An unexplained change in your weight or abdominal pain or other symptoms that are associated with cancer of the colon and rectum.
Okay, thank you. And do you have any specific statistics regarding African American men and women and colon cancer?
So the overall risk is somewhere in the range of 5% for people in America.
Mhm.
And I think in the African American community, I'm not a, the last figure that I saw is somewhere in the range of 7 to 8%. So it's significantly more. Um, but really the biggest take home is this is real and you should pay attention to it. It is not just women or just men. It afflicts both men and women. Um, Before women were, quote, liberated and started smoking, it was the most common cancer that affected both men and women. Now that's lung cancer, but it's in the big three for both men and women. So the big three for women are breast cancer, and then lung cancer, and then colon cancer. And in men, it's prostate cancer, lung cancer, and colorectal cancer. And again, the things that I hear all the time is it doesn't affect, it affects one gender or the other, and that's not so. And it is more prevalent in the African American community, but it's prevalent really in all communities. And what I like to say to patients and to groups is that if I gave you a hand grenade and told you to carry it, you would be careful. If I told you the pin was loose, you would carry it even more carefully. And so being in the African American community, the pin's a little looser, and so you should be even more attentive to the screening recommendations.
Okay, thank you. And as far as age goes, have you treated any patients under the age of 40 for colorectal cancer?
Oh, absolutely. Absolutely. I mean, as young as 20, we've treated patients with colon and rectal cancer. And this is why I say if you have symptoms, you should be checked. So if if you're having bleeding that's not explained and you're 25, then you should be seen and you should be colonoscoped. You shouldn't let your doctor tell you, oh, it's just hemorrhoids or, oh, it's just a fissure. You should actually be evaluated for that because there's been, we've noted and others as well have published on the move towards a younger demographic presentation for colon and rectal cancer. It's unclear why that is, but it recently led to the American Cancer Society moving the recommendation from 50 years of age to 45 years of age. And just so the community knows, what that means is that's where the bulk of people are. But if the bulk of people are in the 45 to 50 range, you're going to have two standard deviations to the right and the left. I mean, you're going to have very young people and very old people who also get colon and rectal cancer. So you want to pay attention to symptoms and make sure you're screened when your time comes.
Okay. Now, when we talk about screening, there's a couple questions about that. One question was, do you think of FIT as an alternative for a colonoscopy? And I'm not sure what FIT stands for, so maybe you can explain that also.
Yeah, so there are a series of different So basically, there's kind of a host of options. So what does screening entail? One screening is a hemocult card, which is kind of the most basic thing, which is just when the doctor does a rectal exam and then they take some of the fecal matter and put something on to develop it, which changes its color if there's blood present. A fit test is something that is looking for, or a Cologuard. These are tests that are looking for tumor cells within the fecal matter, and basically you take a fecal sample and send it back into the company, and they run a test on it to look at things to see if you have anything that would indicate that perhaps you have a polyp or a cancer existing already within your lumen. The benefit of that is that it's simple and it is non-invasive. The next step would be an X-ray study, which would be either something called a barium enema or a CAT scan colonography, which is basically contrast and air is put into your intestine, and then they take pictures of it, and that can show a problem, that can show a polyp or a cancer. And then lastly, the gold standard, which is both diagnostic and therapeutic, is a colonoscopy. The downside to a colonoscopy is it's the most expensive test, and it is a procedure. So even though the risks are very, very low, there is a small incidence of complications from doing it. That being said, it's certainly, in my opinion, I mean, it's the gold standard because you can both find a problem and then treat it. All the other things, if you find a problem, then you're going to have the colonoscopy anyway and redo your bowel prep. So that's kind of what the outlay is, or the explanation is.
Okay, great. And once you've had your initial screening, what are the recommendations regarding follow-up screenings?
Again, these are great questions, and I'll tell you, it's always kind of the recommendations from the American Cancer Society are that you should be screened again in 5 to 7 years. That being said, and really in some places they say 7 to 10 years. That being said, in my practice, I recommend that people be recolonoscoped in 3 to 5 years in general, because in the period of 7 to 10 years, 5 to 7 years, you can go from completely normal to developing a polyp, to then developing a cancer, and even developing metastatic cancer that will kill you. So if I was the Surgeon General and it was my responsibility to pay for colon screening for the entire population of America, maybe I would light upon 7 years or 5 to 7 years, because I would know that some people would die who we missed, but we could pay for things that way. For me personally, in my practice and for my patients, and what I would recommend to you as a group, is 3 to 5 years is a much more reasonable and safer way to do things. It's a little more expensive for the system, but the benefit is, of course, you're not going to get or die from colon cancer. So, and then the caveat to that again is this is all for the entirely asymptomatic patient. If you're colonoscoped and you have a polyp, then maybe you'll be colonoscoped again in a year. If you have a big polyp, maybe you'll be recolonoscoped in 3 to 6 months. And, you know, if you have a small polyp, maybe it would be 3 years. And then if nothing, maybe it would be 5 years. So that's a rather long question to what you were hoping to be a simple answer.
No, that's perfect. Okay, and so I do have a question from our very own Michelle Parker. Can you talk about colonoscopy prep, and why do you think patients are scared to have a colonoscopy?
Well, I mean, you know, the big thing about colorectal cancer, and the reason it is the problem that it is no one wants to talk about it. You know, it's embarrassing. No one wants to hear about poop jokes. No one wants to admit they're having an issue with control or they're afraid of having a bag. And I mean, you as women know how much you don't like to even go and have a mammogram, which is a relatively straightforward endeavor. You're unpleasant while it's unpleasant while you're having the x-ray, but that's it. Whereas for colonoscopy, basically you're giving yourself the runs the night before. It's like having food poisoning, and you have a lot of diarrhea, and then the next day you go to the hospital or the endoscopy center, you have your colonoscopy. And what I say to people, it's a long run for a short jump, because people are afraid of their colonoscopy, and most of the time what they're saying is, what do you mean it's over? You know, they've forgotten what's happening because they have no discomfort around the procedure. And so the thing that everyone is uncomfortable with is the bowel prep, because basically you have to expel all the fecal matter so the doctor can see the lining of the intestine.
Okay. Okay. And just shifting gears a little bit to treatment and surgery, can you speak to what are the success rates after having surgery? And I'm sure a lot of this depends on what stage a cancer is. So I'm not sure if you are able to break that down by stage of cancer.
I'll try for you.
Okay.
So, you know, when you talk about cancer of the colon and rectum, there are 4 stages: 1, 2, 3, and 4. And stage 1 is it's locally confined to the bowel wall. Stage 2 is it's more growth locally through the bowel wall. Stage 3 means that there's some regional spread into the lymph nodes. And stage 4 means that there's metastatic disease. The tumor is spread outside of the bowel to other places, like most commonly the liver and the lungs. And so as a general guide, the numbers are 5-year survival of 80% if you have stage 1 disease, 60% for stage 2 disease, 40% for stage 3 disease, and 5 to 20% for stage 4 disease, depending on the size of metastases.
Okay.
That being said, with the programs that we have pioneered at the Lankenau Medical Center, our 5-year survival for patients with stage 1 disease is 95%. Our overall 5-year survival is 88%. And for those with stage 3 disease, it's 84%. So we're doing far better, I think, by being more aggressive with our surgery and our treatment, and being very diligent in terms of our follow-up. So the wonderful thing about colorectal cancer is not only is it preventable, but if you do have the cancer itself, it's highly treatable. So I try to tell people not to pursue the Ostrich School of Medicine and stick your head in the sand. Just get checked. And even, God forbid, if something's found, we have the ability to take care of it with excellent long-term outcomes.
Okay. And I currently work as a nurse practitioner at Penn, and I work in women's health. And so I was just wondering, I know you talked about the age of screening being between 45 and 50 years old. Have there been any issues with insurance covering colonoscopies when it's done at 45, between 45 and 50, that you know of?
Well, the long and short answer is there's always issues with insurance companies. And, unfortunately, they're kind of jacking up their premiums and increasing your co-pays and trying to decrease the services that are delivered. That being said, Congress has just mandated that they accept 45 as a cutoff, so that should not be problematic. And additionally, it's the rare person who hasn't at some point in their life seen some blood when they've gone to the bathroom. So there is, if you're symptomatic at a younger age, you can be screened. at 45 to 50, everyone should be able to be screened at this point.
Okay. That's great news to hear that about Congress. I had no idea. And then I guess when we're talking about preventive measures, so other than getting your routine colonoscopy, are there other, dietary things you would recommend as far as decreasing risk for colon cancer or colorectal cancers?
We talk about, well, there's a lot of, obesity is tied to colon rectal cancer. So a healthy lifestyle with exercise but the biggest things are avoidance of red meat. It's not to mean you can never have a steak, but try not to have red meat more than once in a week. A high fiber diet, eating bran, salads, whole wheat breads, and a fiber supplement are all very helpful. There's some data to suggest that a baby aspirin a day will help decrease the incidence of polyps and cancers. They're really alcohol and smoking should be avoided or minimized. It's really, and you should also be nice to your mother. But, but that's, no, really, they're kind of the high points.
Okay, great. It looks like I've asked all the questions that were in the chat from the Facebook Live. Did you have any other, quick take-home points other than basically getting the colonoscopies?
I think the biggest thing really, the biggest take-home is there's a lot of fear around this disease. And the fear is its impact on patients' lifestyle. And even the patients who have it the toughest and end up with a colostomy live a rich and full life. And so it's something worth keeping an eye on. Should make sure you have all of your preventive medicine checks, your mammograms, you see your gynecologist, have a pap smear, and that you're also going to have your colonoscopies. These are kind of the basic issues as we become more mature, not older. And I think it's just something that's worthwhile to hear. Don't be foolish and allow yourself to be scared into inaction.
Okay, that's great. And I actually one more question popped in the chat. When you talk about the surgeries that you perform, is there a preference for doing a laparoscopic versus an open procedure? Is there an indication for one over the other, depending on the cancer?
Yes, I think that, in this day and age, clearly, from an oncologic standpoint, in the proper hands, minimally invasive surgery is as good or better from a cancer standpoint, and from a quality of life recovery standpoint is certainly better. That being said, you want the surgery to be done in the way that the surgeon's most comfortable with. You don't want to force a surgeon to do something minimally invasive, laparoscopically or robotically, if they want to do it open, because they're probably more comfortable with that. And this is a technical skill. That being said, for me, 100% of the time, if I could choose the surgeon to operate on me, I would have it done laparoscopically or robotically. If it was the middle of the night and I ended up in a hospital in Podunk and I didn't know the guy from Kane and he said he wanted to do it open, I would say have at it, because they're probably better at that in their hands. But, there's less blood loss, there's quicker return to bowel function, get out of the hospital quicker, less pain, less bowel obstructions, less transfusions, all done minimally invasively. So most of the time, unless it's such a big tumor that you need a big incision to get the specimen out, probably about 95% of what we do, and we do a lot of cancer work, is done minimally invasively.
All right, great. So I think we're just about almost at our hour here. Um, I do want to say on behalf of the Health Committee of the National Coalition of 100 Black Women that we do thank you so much for taking time out to, have this conversation about colon cancer with us and our viewers. We appreciate it.
Well, thank you for your attention, and I hope it was helpful, and look forward to meeting you all in person someday.
Yes.
Stay safe until then.
Yes, thank you. You as well. Have a
Thanks.
good night.
Bye-bye.
Bye.